Welcome back to the ProPA podcast. I'm your host, Prof G, and you're tuning in to another episode of our MSK101 series, where we simplify high-yield musculoskeletal and rheumatologic topics straight from the PANCE blueprint. In this episode, we'll be covering Kawasaki Disease, a pediatric vasculitis that you definitely need to have on your differential when a child has prolonged fever and mucocutaneous symptoms. We'll break down the most testable pearls to help you recognize, treat, and prevent complications in this potentially serious condition. Let's dive in. Did you know that Kawasaki disease is the leading cause of acquired heart disease in children in developed countries? That's right, it can cause coronary artery aneurysms if left untreated, which is why recognizing it early is so critical. So, first, let's start with the kinderpatho. What is Kawasaki disease? Well, it is a medium vessel vasculitis that primarily affects children under the age of 5. The exact cause is unknown, but it's thought to be an abnormal immune response in genetically susceptible individuals, potentially triggered by a viral or bacterial infection. This widespread inflammatory process affects blood vessels throughout the body, including the coronary arteries, which can lead to aneurysm formation. So, how do these patients typically present? Well, the classic presentation is a child with greater than or equal to 5 days of fever, plus 4 out of 5 clinical features. Use the mnemonic crash and burn to remember. C is going to stand for conjunctivitis. It's usually bilateral and non purulent. R in crash stands for rash, and it's usually polymorphous. A stands for adenopathy, typically cervical and usually unilateral and greater than 1.5 centimeters. S stands for strawberry tongue and mucositis, which are dry, cracked lips, and red oral mucosa. H stands for hands and feet. They often get swelling, erythema, and even desquamation. And burn is greater than 5 days of fever. So crash and burn, just remember that. Other features can include irritability, sterile pyuria, elevated liver enzymes, and even arthritis or GI symptoms. So, how do we work these patients up and make the diagnosis? Well, Kawasaki is a clinical diagnosis, but labs and imaging help support the diagnosis and assess complications. Some of the labs that we get include an elevated ESR, CRP, and even a WBC count that's elevated. We can also see thrombocytosis, especially in the subacute phase. We might see some mild transaminitis and sterile pyuria. As far as imaging, an echocardiogram is essential to assess for coronary artery aneurysms. We want to repeat the echo at diagnosis, 2 weeks, and 6 to 8 weeks later. All right, so treatment. We want to start treatment as soon as possible, ideally within 10 days of symptom onset. Treatment includes IVIG, which is intravenous immunoglobulin, and this is given once, followed up by high dose aspirin during the acute phase, and then followed by low dose aspirin until the inflammation resolves and coronary arteries are found to be normal. I want to note here that even though aspirin is generally avoided in kids due to Reye's syndrome, it's indicated in Kawasaki because the benefits outweigh the risks. All right, so now let's look at the book med versus the street med. So, book med, you'll see a perfect textbook case: a febrile child with crash and burn symptoms and an echo showing coronary aneurysms. On the street, you might only see fever and like a weird rash or irritability and conjunctivitis in a fussy toddler. It's often misdiagnosed as viral or strep pharyngitis, so a high index of suspicion is key when fever lingers past those 5 days. All right, some quick clinical pearls to round this up. So, it is the leading cause of acquired heart disease in kids. We want to diagnose using the crash and burn mnemonic and always order an echo. Treat ASAP with IVIG and aspirin and monitor for coronary artery aneurysms. All right, now let's do some PANCE style practice questions. So, question 1: a 3-year-old presents with 6 days of fever, bilateral conjunctivitis, a polymorphous rash, cracked lips, and swelling of the hands. What is the next best step in management? Is it A, start azithromycin, B. Order a head CT. C. Begin IVIG and high-dose aspirin. Or D. Prescribe oral corticosteroids. All right, well, did you figure out the answer? It is definitely C. We want to begin that IVIG and high-dose aspirin. This kiddo in the vignette meets diagnostic criteria for Kawasaki disease, so early treatment prevents those coronary artery aneurysms. Question 2. What is the most serious long term complication of untreated Kawasaki disease? Is it A. Glomerulonephritis, B. Aortic dissection, C. Coronary artery aneurysms, or D. Rheumatic fever? I don't think you'll need too much time for this one, as we just mentioned it. The correct answer is C. Coronary artery aneurysms. These can lead to MI, sudden death, or long term cardiac issues if they're not managed early. All right, so some final thoughts. Kawasaki disease may seem rare, but you'll miss it if you're not thinking about it. Remember, crash and burn and treat with IVIG and aspirin within 10 days to reduce the risk of aneurysms. It's a board favorite and a must-know for the PANCE and your practice. If you found today's episode helpful, don't forget to follow the Pro PA podcast and turn on those notifications so you never miss an episode. Want some visual reviews to go along with your audio? Visit me on my YouTube channel at Professor G PAC. Thanks again for tuning to this Pro PA podcast MSK101 episode. I'm Prof G, and as always, this is the Pro PA podcast, where future pros in medicine are made. I'll see you soon.